I'd like to invite presentation Dr. Zafer Gülbaş, who is my colleagues. Topic is hematopoietic stem cell transplantation and cellular therapy in geriatric hematologic patients. Zafer, please.
Thank you, Chair. And I am going to mention about the experience in the world, and also I would like to compare our experience in Turkey. So, as you know, stem cell transplantation in the geriatric hematologic patients is growing issue because incidence of hematologic malignancies increases with age, but in older patients, the result and the risk is more, and poor outcomes more frequent if you compare with younger patients. So when we have to proceed to stem cell transplantation in geriatric hematology patients, which patients and when? If we look to USA data, CIBMTR data, as you see, autolog stem cell transplantation, green one, and the blue one is the allogeneic stem cell transplantation, is still increasing. So we have to offer our patients more stem cell transplantation. If you look to Autoloc hematopoietic stem cell transplantation trend, in the slide, in the left part, in right part of the slide, you will see the older patients, more than 68, 65. The autolog transplantation is increasing. So every year, autolog transplantation is already done more patients. So we have to do also patients more. If you look the slide, transplants, this increasing in patients with the non-Hodgkin lymphoma, Hodgkin lymphoma, and multiple myeloma. There is three diseases. These three diseases, autolog hematopoietic stem cell transplantation is increasing more in older patients. If you look to younger patients, still decreasing, but older patients, number of the hematopoietic stem cell transplantation is increasing. Approximately 36 of the patients, if you look the last part, going to autolog transplantation in the older patients more than 65 years. If we look to our data, our center is doing the transplantation, refer patients from the others hematologists. So our data, I think, represents the which patients referred in Turkey for the BMT. If you look our data, we do transplantation, autolog transplantation in the red color. We mainly use for multiple myeloma, non-Hodgkin lymphoma, and Hodgkin lymphoma. Mainly multiple myeloma, non-Hodgkin lymphoma, and then Hodgkin lymphoma. If you look how many percentage of the patients more than 60 years, so our center data shows that lymphoma and multiple myeloma patients undergo the autologous stem cell transplantation, 35% more than 60 years old. So in Turkey, if we compare the CIBMTR data, in our patients, similar, we are offering in the Turkey to myeloma and lymphoma patients. How about the allogeneic stem cell transplantation? If you look to CIBMTR data, this shows that unrelated, this is the red one, increasingly have been used for the allogeneic transplantation. The others, if you look, the green color, also increasing. This is the haploidentical transplantation. If you look to our data, if you look to trends in allogeneic hematopoietic stem cell transplantation in the recipient age, the older age, if you look to blue color, 10 or 15 years ago, it is less, but increasingly has been used in older patients. So now, 2019, quarter of the patients is older patients. So we have to offer more allogeneic stem cell transplantation like Autoloc transplantation to older patients because hematologic malignancy is more frequently seen in older, and older patients should, if necessary, should go to allogeneic hematopoietic stem cell transplantation. If you look to disease in the bottom, acute myeloblastic leukemia, acute lymphoblastic leukemia, and MDS, and after Hodgkin lymphoma. So mainly allogeneic stem cell transplantation has been done in patients with AML, ALL, and MDS, and non-Hodgkin lymphoma, and then others. If you look to our data, this is the HLA match. Mainly we do allogeneic stem cell transplantation for referee patients, mainly AML, and then ALL, and then non-Hodgkin lymphoma and MDS. So in Turkey, we are using mainly for patients with AML, ALL, MDS, and then lymphoma. If you look to total number, HLA match related, unrelated, and haplo allogeneic stem cell transplantation percentage, more than 65 years old patients, it is 15%. If you look to CIBMTR data, this should be 26 like this. So I think that in our country, we are offering less allogeneic stem cell transplantation for AML, ALL, and MDS patients for older patients. If you look to literature, the allogeneic stem cell transplantation more increasing in patients older than 60 years, 70 years. So we have to, if you look to more than 70 years old patients, the survival rate is more better than the standard treatment. According to these slides, we have to offer older hematologic patients hematopoietic stem cell transplantation. But for the treatment of older patients, we have three choices. One is non-transplant therapy. The another one is autologous stem cell transplantation. The another one is allogeneic hematopoietic stem cell transplantation. How we decide how we do that? The sites should be do according to two factors. One is patient-specific factor. Another is disease-specific factor. The patient-specific factor, geriatric assessment and calculation of the hematopoietic stem cells transplantation comorbidity index. Though those two factors is the generally essential factor, but also you can look the patient's walk speed, health, age, performance status, but the first one is the more important. Disease-specific factor, you have to look the other disease-specific factor like prognostic and genetic markers. Decision-making process for the transplant is really important according to the center experience. Transplant timing is really important for older patients. You have to give the beginning treatment, but you shouldn't cause the patients increase the comorbid factors. So your treatment should help the patients and should decrease the comorbidity index, not increase the comorbidity index, not give a problem to the performance status. So you have to optimize the treatment, and at the beginning you have to evaluate geriatric assessment, comorbidity index, and organ functions, and the disease risk altogether. And after, you have to decide when you have to, the patient needs a transplant or not. If the patients need the transplant, you have to start treatment of the disease and transplantation plan together. Decision for the autologous or allogeneic transplant. For the patient-specific factor, for older patients, geriatric assessment and comorbidity index calculation, the most important one. There is calculation, automatic calculation, internet websites. If you write comorbidity index calculator, you can find easily Google. So please do, if you diagnose a patient older, comorbidity index calculation at the diagnosis, and then ask the question, the patients need autologous or allogeneic transplantation or not. A lot of publication you can see in the literature. The most important ones published Maffei and colleagues, and they show that hematopoietic comorbidity index and geriatric assessment can help treatment mortality and overall survival risk calculation. And which one? Usually the easy one is, and more standardized one is calculation the hematopoietic comorbidity index. And also the other cognition function, psychologic function, nutritional status, polypharmacy, but those are subjective, but the objective looks like hematopoietic comorbidity index calculation. If the patient's older than 65, if the comorbidity index 0, 1, 2, you can, if the patients need the allogeneic stem cell or autologous stem cell transplantation, you can proceed. For autologous transplantation, you can use comorbidity index, also 3 hematopoietic comorbidity index, sometimes 4. But for allogeneic, more than 3, usually it is risk condition for the patient's allogeneic transplantation. So hematopoietic comorbidity index for allogeneic transplantation, if the patient's hematopoietic comorbidity index 0, 1, 2, safe, but 3, it depends the patient's disease condition, disease risk. So you have to decide according to patient's disease condition. But if more than 4, 5, you should 2 times think about the allogeneic stem cell transplantation. Disease, let's come to disease-specific factors. Disease-specific factors, another issue. If you go to autologous or allogeneic stem cell transplantation, for the autologous stem cell transplantation, if the patient's complete remission or the disease controlled, you can have more good results after the autologous transplantation. So proceed to autologous or allogeneic transplantation. Disease should be controlled, and the patient's prognostic factors really important. for autolog transplantation, myeloma high risk or lymphoma high risk, you should maybe do more earlier. And pre-transplant therapy really important. Which treatment you have to plan before the transplantation, and disease status at the transplant time. If the patient's at the CR, you will take more good results with the autolog or allogeneic transplantation. Another issue is for autolog and allogeneic transplantation, choice of conditioning regimen. For autolog transplantation, myeloma, it is really standard. This is easy. But for lymphoma, sometimes you couldn't find some drugs, and then you have to decide which regimen for which patients. So it depends the patient's comorbidity factors also. It depends the patient's age. And also you have to check long-term disease survey and cure of the disease. You know, the new drugs is coming. Before me, the speakers speak about BiTE anticorps and CAR-T. So new treatments is coming, and how can we decide clinical trials with the new drugs or standard treatment with the allogeneic or autolog transplantation? It depends the center experience and center decision. If you look at disease status at the transplantation, this is really most powerful factor for leukemia patients. If the patient has disease on the partial remission and survey and the response rate is less, if the patient is CR1, result more better. If the patient is CR2 when you are going to transplantation, result more bad. So if you diagnose the patients, you have to decide for patients, should you go to transplantation CR1 or you should wait until CR2. But generally, if the patients needs a transplant for the leukemia or MDS patients, you should go at the CR1 for the transplantation if the patients need transplantation. And the comorbidity index, if you do less after every treatment, increase the comorbidity index in older patients. If you look to overall survival, leukemia-free survival, if the patient CR1, it is more. If the patient CR2, less. If the patient is not CR2, and then the result really more bad. So the disease condition is really predictor factor for the long-term survival. Post-transplant problems in elderly patients. If you do the transplant, allogeneic transplant, older patients, usually immunity recovery more slower. So graft versus leukemia or graft versus lymphoma effect develops slowly. And then disease relapse risks more if you compare the younger patients. And slow immune recovery, the older patients will have more frequent infection. And the older patients has low immunoglobulin IgG levels more. So you have to check humoral immunity and cellular immunity. You have to think, and you have to give supportive treatment, prophylactic treatment on older patients more. And you shouldn't discontinue this type drugs. Another things, if the patient has developed graft versus host disease, steroids can have more problems in patients with older patients, more diabetes, more myopathy. So you have to use less steroids if the patient has developed GVHD. So it is sometimes you have to use new drugs and less toxic drugs for the control GvHD. And for the older patients, younger patients does not need family support more and more. But the older patients needs more and more family supports. How can you provide family supports? If the physician should decide going to allogeneic transplantation, for autoloc transplantation maybe it is not can be more important, but for allogeneic transplantation, family support before the transplantation plan, you have to evaluate family condition and you have to discuss with the family, family support can be done or not. This is really important issue because you can do the successful transplant, but after, if the patients develop some infection, you can suddenly lose the patient's simple infection because of the less family support. In developing countries, usually talks that elderly AML patients are often under-treated. Many new agents available, and the patients couldn't reach this type drugs. And allogeneic transplantation, if you compare in older patients with the new drugs or standard treatment, cure rates more than the chemotherapy. Or we have to think if the patients can go to stem cell transplantation for AML, we should offer this treatment. But we should offer this treatment CR1, if not CR2. Don't be late for the transplantation time if the patient needs the transplantation. Those are the CIBMTR data. Before every year, supporting treatments is increasing, new drugs increasing, and donor, we are finding good donors, unrelated donor bank, and then results coming more better. If you look, the results, if you compare the 10 years ago, more better. If you look the age, also this is comparable. And if you look the older patients, yeah, you have to survival rates. Yes. For the treatment of elderly AML patients, you can choose for older patients non-intensive or intensive treatment. There are a couple of things, but the new drugs also can be useful. And venetoclax is the new drugs, and venetoclax combination with demethylating agents giving more promising results. And we are obtaining more CR in patients older AML. And this is our data. We compared the patients 50 and 60-year-old and more than 60, and the results comparable. So we have to offer for patients more transplantation if the patients had bad risk disease factors. For ALL, there are new drugs. Blinatumab, inotuzumab, CD19 targeted CAR T cell, and very promising. And if you look, blinatumab giving more good results, and inotuzumab also give more best CR rates. And allogeneic stem cell transplantation also older than 60 years old patients giving good results. So for the older patients, if the patients had bad risk, also we have to offer allogeneic stem cell transplantation. if you look the CRBM-TER data, if the patient CR1, ALL result really more promising. If the patient CR2, less promising. So we have to evaluate at the diagnosis for patients ALL, this patient needs allogenic BMT or not. If you look to the years, according to CRBMT result, the result getting more improved. The less time, ALL long-term survival result going to 60-70%. So this is really promising. And we should offer more. In our center in Turkey, I think, in Turkey, in our center, we refer patients really less, 5% like this. If we compare the CRBM-TER data, in our country, we are less promising, less giving chance to allogenic BMT. We should improve this practice to increase the patients for allogenic stem cell ratio. If you look to MDS patients, I think there is, bir yanlışlık var. Nasıl gidebilir? Sorry for the Evet. For MDS patients, elderly MDS patients, also we can do hypometeoritic agents or like acute leukemia treatment we can do. If you look, the CR rates, number of transplants in the first part of the graphics, increasingly used for the patients. And the survival also increasing more than 70 years old. So in the world, for the MDS patients, more frequently allogenic stem cell transplantation have been done for the older patients. If you look to years, and success rate is increasing for the also MDS patients, and long-term survival 50-60%. For MDS patients in our referred to our centers, we compared to between 50 to 60 or 60 year, more than 60 years old patients. Our rates 30-40% rate. Why? Because the referring times for the patients not earlier. So in our centers, we have to think about how can we send the patients more earlier, more good condition, less comorbidity index time for the allogenic transplantation. What about for lymphoma? For lymphoma also, the patient age is really important. If the patient age older, then risk is increasing. Mortality is increasing. In our patients, referee patients, we compare the 50 to 60 and more than 60 years old persons, but long-term survival really comparable with 50, 60 years old patients and more than 60 years old patients. Approximately 50% of the patients has long-term survival relapse lymphoma patients. If the patients CR, the results allogenic BMT really more better. For allogenic stem cell transplantation, older patients, when we shouldn't go to allogenic, when we should go to allogenic. If the patient's disease comorbidity index 0, 1, 2, we should go. We should do geriatric assessment. Family support and financial support really important. This is okay, then we have to proceed. If the financial support, family support is not enough, and the hematopoietic comorbidity index more than 4, we shouldn't go. But hematopoietic comorbidity index 3, and then we have to decide according to patient's condition. As a result, physiologic measures more important than the chronologic age for allo-BMT. Alternative donors increasingly use allogeneic BMT, and pre-transplant functional status, especially comorbidity index, should be used more frequently for deciding allogeneic BMT. Risk-adapted treatment strategy really important. Before the MRD, before the stem cell transplantation is MRD negative, the success rate is increasing. If the patient has highest risk of relapse, post-transplant maintenance treatment also should be considered. This is the new developing issue. Thank you. Maybe I can talk about the CAR T cell. In Turkey, we haven't had opportunity to use CAR T cell. For the CAR T cell, in the USA, lymphoma is really increasing to using the CAR T cells. First started with the ALL, but if we look to American statistics, for patients with lymphoma, CAR T cell using increasing. But the CAR T cell usage has a lot of toxic effects. We have to have experience about the management of these toxic effects. And we will see in the future, according to results for patients, myeloma, lymphoma, and leukemic patients about the CAR T cell treatment. Another issue, bite cell antibodies. Dr. Cordoba mentioned about the usage of these antibodies. I think for older patients, another alternative to stem cell transplantation to use bite cell anticorps. Thank you.
Thank you for presentation. Zafer, what about the donor? Older siblings match donor or young, one or two mismatch mat? What about? What do you think?
Yeah, this is a discussed question. Everybody asks about himself this question. Should I, because the older patients has not donor. If you look, older patients, only 3% of the patients has donor. So we have to proceed the unrelated donor search. But if the patient has older brother or sister AHLA match, usually authors about this subject still prefer to use HLA match donors if the donor is good condition. So this is discussable. If the donor is appropriate, at that point, first HLA match sibling, older donor, but if some problems, then younger donor, haploidentic, looks more better for this type patients.
Also, I know you are a member of EBMT Acute Leukemia Working Party. Also, I know you are co-author and published Haplo, Allo. What about in the future haplo transplantation for elderly patients?
I think the important thing is when you are deciding to proceed the allogeneic stem cell transplantation for the patient, if the patient general condition, comorbidity is index really low, you have to proceed the allogeneic stem cell transplantation CR1. When I look our patients and EBMT data, if you do the stem cell transplantation haplo CR1, the results really good and results similar to HLA unrelated donor results, almost similar. There is not much difference. You can reach easily the haplodonor. Increasingly used haplodonor, but still unrelated donor first choice. If the patient has time, 10 to 10 unrelated donor according to EBMT data first choice. But if you do not have enough time, you can proceed to haplo. And also there is not much difference between 9 to 10 and haplodonor results. From my point, if the patient's CR1 and the comorbidity index 0-1, haplo can be used instead of unrelated donor. This is my response.
Also, I want to learn, what about the multiple myeloma patient? We discuss always one or two autologous settings for cure or PFS. What about the elderly patient?
For
One
elder,
autologous
yeah.
or two autologous?
For the patients has low risk, one autologous transplantation. If the patient has high risk, and if the patient has day 100 still minimal residual disease, results shows that to proceed the allogeneic autolog BMT can be better instead of the chemotherapy. If the patient, because if you do not do, for example, 69 years old myeloma patients with high risk to transplant, after 5 years the disease comes, or after 3 years, and then you couldn't give this opportunity to the result maybe. So if the patient's day 100 still has minimal residual disease, but response is the first transplant is really good, we recommend to proceed the second transplantation. But there is no response, no the second one. But high-risk patients, also the second transplantation, more better than the one transplantation.
Other question is early transplantation or late transplantation for multiple myeloma. What about the elderly patient? New drugs area.
Yeah. This discussed a lot of times. Some persons less collect the stem cell, less weight, but standard practice in the world everywhere, everybody supports the first line autologous stem cell transplantation. No centers really do the late transplant. Most 90% of the centers do the transplant earlier.
Last burning question. What about the solid tumors? Elderly patient, allogeneic settings, new CAR T cell area. What about?
Yeah, CAR T cell really important site. Getting more frequently, according to hematologic results, then it can give information about the other disease. For CAR T cell treatment, in USA, it has been discussed also the autoimmune disease and the other non-hematologic benign disease, rheumatologic disease, or every disease CAR T cell. Autolog allogeneic transplantation and for example, autolog transplantation first discussed with the breast cancer, ovarian cancer, but after the result was not good. But the first result, clinical trials, shows promising results for the solid cancers. And we probably this we do not have an experience, but American clinical trials data giving promising results for the solid cancers.
Are you suggest the Gcse accreditation center for elderly allogeneic settings, also CAR T cell?
For Gcse, so Gcse accreditation is good for every practice, for life, for general daily activities, for food, everything. Quality control is really important. Because every quality control, you need person, you need money for all activities. If you do, it is the best.
Experience with allogenic stem cell transplantation, after allogenic stem cell transplantation in elderly patient, which type of hematological malignancies you prefer to continue with maintenance?
For elderly patients, we routinely do for patients with AML, high risk and standard risk patients, not good risk patients. And if the patient, good risk patient, in spite of the treatment, still has minimal residual disease. For example, you gave the patients 3 consolidation and still 821 translocation is positive, inversion on autopositive, and then you have to proceed. Usually, we would like to do more patients with AML. And if we look at our results, I think slide also I showed, we do most commonly for patients with AML, ALL, and then non-Hodgkin lymphoma.
Thank you, Zafer. Excellent presentation. Now, last presentation. Topic is handling COVID-19 under malignancy in geriatric hematology. Speaker is Dr. Niccolò Matteo Battisti. Please, Dr. Niccolò.
Thank you very much to the conference organizer. Thank you very much, Professor Ilan, for inviting me to this conference today. My name is Niccolò Battisti. I'm a medical oncologist. My main disease focus is breast oncology. So I'm not a hematologist. And I work at the Royal Marsden in London. I'm also the president-elect of the International Society of Geriatric Oncology. And today I thought I could discuss with you a few aspects on ways we can adapt the care of all the patients with cancer during COVID-19, obviously also including also those with hematological malignancy. And as you probably already know, our society, SIOG, has been doing a lot over the last 18 months. We also have a specific COVID-19 working group that has been issuing recommendations on these aspects and also on the rollout of the vaccines. These are my disclosures. So I will start with a brief introduction about what we know about outcomes of COVID-19 in older individuals and those with cancer. And then I'll move on describing a bit what is the complexity of managing cancer in older individuals, especially during COVID-19. I will then move on describing what we can do in terms of ensuring that we are still delivering personalized and adequate care to this patient population, even during the pandemic. Discuss a few implications when it comes to anti-cancer treatment decisions. And then a brief outlook on vaccines rollout against obviously COVID-19 in this patient population, and then draw a few conclusions. So first of all, what we know about COVID-19 in older individuals, the main points are really that COVID-19 may present more frequently with symptoms in older individuals. This was already apparent last year when the pandemic kicked in. Compared to younger patients, a significantly higher proportion of older individuals do develop symptoms. But at the same time, there is a significant proportion of these patients that present with subtle findings that may be put down to many different problems, obviously in the context of an increasing burden of comorbidity. So this is something that obviously clinicians in the oncology and I suppose also hematology setting should always be aware of. And the issue with older people is that sometimes the symptoms are non-specific, so not necessarily just respiratory symptoms, but also an increased risk of falls, confusion, and worsening functional impairment. What we know as well is that age is a predictor of adverse outcomes of COVID-19. Again, this was already shown in the early days of the pandemic on Chinese data and also Italian data, showing, as you can see here, a higher risk of hospitalization in older individuals, obviously in this case series, those over the age of 80, and also an increased risk of mortality in the older patient population. So it feels like, again, these patients are a bit doubly disadvantaged compared with younger individuals because they are also at increased risk of experiencing adverse outcomes during the pandemic. And the data from the COVID-19 and Cancer Consortium database provides a very nice insight in a large case series, real-world case series from the States, Canada, and Spain on almost 1,000 patients. These were patients with a median age of 66, ranging from 18 to over 90, so obviously including also older individuals. And as you can see here in this pie chart, there was a significant proportion of patients with solid malignancies, but there were also some patients with hematological malignancy, especially lymphoma and myeloma included in this case series. And the investigators of the CCC19 analysis actually looked at also burden of comorbidities, for example. And as you can see here, a significant proportion, 1/5 of these patients had more than 4 comorbidities. There was equal representation among sex, and actually the majority, a significant proportion of these patients actually had disease remission, almost half of them. And obviously half of these patients didn't have any systemic anti-cancer treatment given over the previous 4 weeks when the analysis was conducted. And what this analysis showed that on the multivariate analysis, actually predictors of early overall mortality is age, male sex, smoking status, which is perhaps not surprising, and obviously the presence of progressive and active disease. But obviously also an increasing burden of comorbidities and also functional impairment that really show how it is important for these patients to actually have advanced care planning discussions at the very onset of the presentation, to a very frank discussion with them about ceiling of care and so on. What this analysis show is actually that consistently with previous retrospective data, there was a higher risk of mortality without ICU admissions in the older patient population. But why is so complex managing cancer in older individuals? Obviously, in the context of the pandemic, COVID-19 represents an additional competing risks of morbidity and mortality in this patient population. And we also know very well that all the patients with cancer have gradual organ function decline affecting multiple systems, but may also have an increased burden of comorbidities, an increased risk of toxicities, complications on anti-cancer treatment approaches. They may have cognitive impairment, functional impairment, malnutrition, polypharmacy, psychological distress. And in this context, we need to remember that quality of life is a key endpoint, especially for these patients that typically have a shorter life expectancy compared with younger individuals with cancer. Key problems in this patient population that we have highlighted in our first publication available on JGO from the COVID-19 working group are certainly the issue of social distancing and isolation that in these patients may actually cause problem in terms of provision of supply, grocery shopping, but also availability of medicines and prescription. May also cause a lot of psychological distress and malnutrition. And this is something that we can, for example, address with the involvement of social services, charities when available, remote prescribing, remote drug delivery, and obviously also use technology to reach out to these patients, even if they are no longer able to attend our clinics. A key aspect that we always have experienced over the last 18 months is also the fact that we have been limiting the access to hospital of caregivers that frequently these patients have to rely on. And this has caused an awful lot of issues with functional impairment, may cause issue in the presence of mobility problems and cognitive impairments for these patients. So again, these are policies that, in my opinion, should not be applied as a blanket policy, but actually evaluated for a patient on a patient-to-patient basis. And whereas, for example, some of these patients do require somebody bringing them to clinical appointment in clinic or hospital appointments in general, we should actually allow that. And also use patient navigators where available and teleconsultations, perhaps with video as well. Which leads me to the next problem. Teleconsultations are a great resource to use in the context of the pandemic, but equally we cannot make assumptions that all these patients will be actually able to benefit from teleconsultations. We know that in the older age group, we deal with a significantly higher burden of hearing impairment, visual impairment. And again, we need to personalize the management of these patients and actually review the possibility of going for teleconsultation only for those patients actually able to engage with this sort of approach. Another aspect that we, for example, we've been implementing in my hospital is self-administration of some systemic anti-cancer treatment. Again, I am a breast oncologist. For example, trastuzumab, which is now which is obviously available as a subcutaneous injection. We've been asking patients to self-administer trastuzumab for the at least last 12 months. But again, we cannot assume that all these patients will be able to cope with this approach, because again, of functional impairment, mobility disorder, cognitive impairments, polypharmacy, that may also increase the risk of medication errors. And again, the key aspect is to review the individual patient needs and perhaps use some dedicated team that, for example, in my hospital, we call home care, with nurses, dedicated nurses that are actually able to deliver specific systemic treatment in at home of our patients. And for example, in my hospital, our hematology colleagues have been delivering bortezomib, Velcade as well, at home via our home care service, again in the hematology field. And finally, one key aspect is really the increased workload and pressure on supportive care teams that are so important for the management of all the patients. We've been dealing with an awful lot of need in terms of symptom control and quality of life aspects, because again, it's become more difficult to address these needs in the community, also for local palliative care teams. So we should always remember to address very thoroughly any needs that these patients may have in terms of symptom relief, for example, already in the clinic, so that there is continuity of care when actually they leave the hospital after the consultation. What can we do in terms of managing these patients? Well, as you know very well there is substantial bulk of evidence suggesting that actually using comprehensive geriatric assessment in this patient population is a standard of care. This is something that we have learned from our geriatrician colleagues. As you know, CGA is a diagnostic and therapeutic approach, looking at all key interventions, all key domains of the well-being of all the patients. Again, comorbidities, polypharmacy, functional status, cognition, mood, nutrition, fatigue, geriatric syndromes, with a number of tools that have been validated also in the older cancer patient population. And the key aspect is being able to address these impairments, these geriatric impairments, with personalized, again, interventions. And we know that this approach, an oncogeriatric approach, now has substantial benefits in this patient population. Historically, we have found that, for example, using CGA in older patients with cancer can improve our ability to predict complications and functional decline on anti-cancer treatments in general. We can become much better in predicting prognosis for these patients. We can shift treatment decisions. We can find many problems that actually more routinely used assessments like Karnofsky or eco performance status actually are neglecting. And as you know, last year, the American Society of Clinical Oncology conference, 4 randomized clinical trials actually did show benefits that in general the oncology and I suppose also the hematology community find a bit more attractive. And these benefits are a reduction in the risk of severe systemic treatment toxicity, better quality of life for patients undergoing systemic anti-cancer treatment. And again, in this patient population, also a reduction in the risk of hospitalizations and increased completion of advanced directives, which is so important also in the context of COVID-19. And for those patients, again, this might be less relevant to the hematology field, but those patients actually requiring surgery, there is some initial evidence suggesting that this approach can also reduce the need for postoperative inpatient stay and ICU admission, which is also quite important in the context of this pandemic. The challenge is, how are we going to deliver geriatric assessments during the pandemic, given that obviously we do need to see patients in order to perform them? Well, actually, if you look at the tools available, there are, first of all, some tools, geriatric screening tools, that actually we can deliver remotely. And these are, for example, the G8 and the VES13, that are actually tools that have been extensively validated in the older cancer patient population. And again, perhaps with the help of telehealth, we can still aim to screen this patient population for frailty, and then identify those that actually do require a more extensive CGA and in the hospital. And we have models that have been trialed globally. For example, this is one of these examples, the University of Rochester SoCare model, where the local team has actually implemented a remote way to conduct geriatric assessment in older patients with cancer by means of using telehealth, with a pre-visit evaluation, which was delivered over the phone by a nurse navigator, with an abbreviated geriatric assessment, and then followed by a teleconsultation with a multidisciplinary team involving a nurse, an occupational therapist, a geriatric oncologist, and then a wider group of multidisciplinary team members. And again, as you can see here, our colleagues have been still able to look at all these key domains: function, comorbidities, polypharmacy, nutrition, cognition, social support, and activity and mood, that are so important in this patient population. Let me now discuss a few aspects about the management of anti-cancer treatment in this age group during COVID-19. First of all, the 3 key items, let's say, to always evaluate in this case are, first of all, the patient, then the disease, and the treatment. we really need to understand, first of all, what are the patient preferences in terms, for example, of, again, face-to-face versus remote consultations, what the patient feels comfortable about. We should actually look at, obviously, comorbidities, and again, lung conditions as well that might increase the risk of adverse outcomes with COVID-19. What is the life expectancy of that patient, and what are the potential benefits in terms of survival in this patient population? What is the degree of social support that this patient can rely on? Because obviously that might change. May have a significant impact on, again, the way we deliver our care for that person. And again, very practical aspect like transport and logistics. And we can understand all these key factors if we again aim to conduct geriatric assessments, even in the context of this pandemic. And obviously you have to consider the disease, the tumor itself, what is the biology, what is the burden of disease and symptoms as well, what are the expectations in terms of response, disease control, and whatever anti-cancer treatment approach you are considering. And certainly the treatment, is this a curative or a palliative treatment, adjuvant, neoadjuvant, for example, for solid tumors? And again, what type of treatment are we considering? Is this a cytotoxic treatment, myelosuppressive treatment, or not? Is this a targeted agent? Is it an endocrine therapy, immunotherapy? Is this a local regional treatment like surgery? Can be conducted in open versus endoscopic approach? Can it be conducted in election versus emergency? What is the schedule and the dosing of this treatment? What is the route of administration that can again allow, for example, remote delivery of the drug? What about the use of primary Gcse prophylaxis? For example, in my hospital, again, in the breast cancer patient population, we've been giving everybody primary Gcse prophylaxis from the very start of the pandemic, even with our perhaps less myelosuppressive regimen compared with the hematology field. What is the duration of the treatment? We know that this is a key predictor of adverse outcomes in all the patients with cancer. And again, can we perhaps adapt when it comes to radiotherapy, the fractionation of this specific treatment? Are there any additional requirements in order to be able to deliver this treatment approach in terms, for example, when it comes to surgery, anesthetic input, ICU input, and so on? What are the expectations in terms of side effects, recovery time? Are there any alternative options that we actually can consider in this patient population? And a key aspect that I would like to highlight here is also the use of what we call chemotherapy toxicity prediction tools that are available and have been developed and validated in the older cancer patient population, and can actually allow you to understand what is the individual risk of that person to experience severe grade 3 plus toxicities. As you know, there is, for example, the CRASH score, there is the Cancer and Aging Research score, and you can use these tools really to improve discussion with patients, and where you may have patients that may be absolutely willing to consider a determinate specific risk of severe toxicity along with a specific benefit, expected benefit. There are some that actually may not be willing to take it. And again, as you can see here, these tools include, for example, lab tests like, again, LDH, hemoglobin, liver function, creatinine clearance, clinical parameters, blood pressure, geriatric domains, mini-mental, mini-nutritional assessment, performance status, falls, and so on. And you can use this tool, again, to triage patients and understand whether, for example, in the context of this new competing risk, which is COVID-19, that's a treatment that you really want to offer that to that patient. So I just thought I could mention a few practical tips. I'm afraid these have been more relevant probably to the solid tumor, solid oncology field. But I guess the main take-home message here is to use the evidence which is available, you know, in the solid oncology field, and also I'm sure in the hematology field, to understand whether there is, again, for example, the opportunity to adapt the delivery of systemic treatment in this patient population. For example, using oral versus intravenous treatment to limit the footfall in the hospital, using shorter courses of treatment where there isn't, for example, a clear benefit within a prolonged course of treatment, or where there is evidence of no detrimental impact if you, for example, consider a shorter course of systemic treatment. Again, in the breast oncology field, we have one study showing that, again, in the early stage HER2-positive breast cancer patient population, 6 months of trastuzumab may naturally not be inferior to 12 months, or where there is the opportunity to de-escalate systemic treatment to, again, reduce the risk of severe toxicities. But also delaying systemic treatment. Again, I guess this is probably less relevant to the hematology field, where sometimes you really feel the pressure to start treatment ASAP. But I guess if you are dealing with the indolent disease, then you really have to ask yourself, do I need to start the treatment right now? Or maybe can I wait a while longer, so to allow the situation maybe in my local geographical area to improve with regards to obviously rates of infection. And obviously the key question is, do I need to give that patient systemic treatment? Can I avoid it if, for example, there isn't any clear evidence that leads to improved outcome specifically in the older cancer patient population? And the same considerations are also valid when it comes to radiotherapy. Again, our working group has been issuing some suggestions on how we can adapt radiotherapy, for example, with shorter course of radiotherapy or hypofractionation as opposed to longer course of treatment, intraoperative radiotherapy, again, in the breast cancer field, or single fractions radiotherapy rather than multiple fractions. Again, for example, in the case of bony metastatic disease and metastatic cord compression. And again, there is the opportunity to consider delaying radiotherapy. Again, this is probably a bit more valid in the solid oncology field. Again, omitting radiotherapy where there isn't any significant substantial evidence of a benefit in the older age group, or where there are effective drug treatment options like, again, analgesia when it comes to palliative radiotherapy. And again, this might be a bit less relevant to the hematology field, but we have also issued recommendations in terms of surgical management that our surgeons have been really spending a lot of time to understand, triage patients over the last 18 months to, again, prioritize those that are most likely to benefit from local regional treatments as opposed to those that you may manage or with systemic treatments as a temporizing measure, but also considering minimal invasive procedure like, again, laparoscopy versus laparotomy again, mostly in the solid oncology field. And again, there is the opportunity, as I mentioned, to delay surgery as well. For example, in the breast cancer patient population, we can use neoadjuvant endocrine therapy for luminal breast cancer, especially in this patient population, or omitting surgery, for example, with primary, again, endocrine therapy as opposed to surgery in older women with increased burden of frailty. A key aspect, obviously, is multidisciplinarity. Obviously, we are all very used to work as a multidisciplinary team within our areas of expertise. Again, in the breast oncology field, we are used to have a long discussion with obviously our radiation oncology surgeons and nurses about patient management. About this is incredibly important for all the patients with cancer because of their complex needs, which really aim to involve a a large multidisciplinary team, including were available also geriatricians and allied care professionals, for example, dietitians, pharmacists, physiotherapists, occupational therapists, and social workers, psychologists, supportive care teams, primary care to ensure continuity of care in the community. And when it comes to COVID-19, very important to engage with your infection control team. Obviously, that should really become part of this MDT. And then a few last slides about the COVID-19 vaccines. Obviously, as you know, these have been evaluated in large trials. We have reviewed the data on COVID-19 vaccines in all the patients earlier this year. As you can see here on the right, the various studies have been recruiting a different proportion of all the patients. Perhaps again, there is much more data on the older patient population for the Janssen study. Almost 50% of these individuals were actually older. But again, the key message here is that again they should be used also in this older patient population, even in the context of perhaps less benefits in terms of antibody reaction and so on. We should actually protect these patients because obviously they have cancer and they are older and they are doubly disadvantaged. We also review within the COVID-19 working group within SAIG also what's been going on in the world in terms of prioritization of older patients with cancer among different countries. Again, I work in the UK. Here in the UK, we've been lucky enough to have our older patient population prioritized when it comes to rollout of the vaccine. This has not been true for other countries in the world, but again, we should be really mindful of those data showing worse outcomes in this patient population and actually advocate for these patients to be prioritized in our institutions and in our countries for the delivery of the various vaccine program. And again, there are very, very early data now showing also that there is a lower rate of serological response to COVID-19 vaccine in all the patients with cancer, as opposed to, for example, controls. Here, this small study looked at healthcare worker in a big hospital in Rome, in Italy. But again, this does not mean that these patients should not be offered and prioritized vaccines, because again, even this lower serological response in this patient population is definitely worth the effort in order to protect them. And this data will come, I suppose, from a number of other real-world experiences that have been investigated worldwide. So earlier this year, we also issued some recommendations in terms of the rollout of the COVID-19 vaccine programs worldwide. Again, as I already mentioned, we think that these patients, older patients with cancer, should be prioritized for the delivery of these vaccines because they have an increased risk of mortality and complications. They should be given vaccines as soon as possible, and perhaps prioritize the vaccination of these patients when they recover bone marrow function, if they're having obviously myelosuppressive treatment, to give them the best chances of an adequate immune response. But we should still persevere with our intervention strategy in the community, obviously social distancing and hygiene, mask wearing, in order to protect our vulnerable groups in our population. And the key aspect that we highlighted in this position paper is really prioritizing also low and middle income countries, now that significant proportion of the general population are doubly vaccinated in high income countries, because obviously we need to make sure that everybody gets access to the vaccines, because we want to limit obviously also the development of new variants that may be challenging our ongoing efforts. And obviously, within this position paper, we also mentioned the importance of prioritizing within the older cancer patient population, also those with a more disadvantaged background from a social point of view, a medical point of view, the importance of keep pushing with educational campaign to reassure the general population about the safety and the efficacy of various vaccination programs. There is an awful lot of statements from many non-experts at the moment on this topic, and we should as healthcare professionals make sure that we address these concerns systematically in the clinic to reassure our patients. And I guess already mentioned this, but I guess we need to also understand what are the long-term outcomes of vaccines in the older patient population? How does the immune response to, prompt by this vaccine behave again in the older cancer patient population? Again, to develop personalized strategies, vaccination strategies for this specific group of patients that may be different compared with the general population. So, in conclusion, as I mentioned, COVID-19 certainly represents a key additional risk, competing risk in this patient population, but there is still an opportunity to aim for a personalized approach also in the context of the pandemic. As we know, over the last 20 years, we've been moving away from simply driving anti-cancer or lymphoma or myeloma treatment decisions just based on histology, grade, and stage. We use a number of biomarkers now to inform discussion with our patients, and we can still do that also during COVID-19 when we look at our patients and move away from simply, considering chronological age or performance status, but actually still deliver administer geriatric assessments to estimate individual risks and benefits from our anti-cancer treatment approaches in this group. So I would say my take-home messages are really get to know your local epidemiology, which is becoming increasingly important to make sure that you are protecting your older patients with cancer as much as possible in terms of variant, in terms of rate of infections. Speak to your infection control team. Always remember typical presentations as well when you see these patients in the clinic. Consider if at all possible, and if patients feel comfortable with this, telemedicines, and use telemedicine as an opportunity to deliver geriatric assessment also remotely. And obviously, which is very important in the old age group, have a look at the bigger picture. What is that person life expectancy? What is that person? What are the person chances of response, disease response on whatever anti-cancer treatment? What are their preferences? And sometimes in this context, again, de-escalated strategies may actually be safer and actually equally beneficial, specifically in this age group. And again, please continue recommending these patients to get their jab in their arms as soon as possible, and whenever these are made available for them, to give it the best chance of protection. This is just as like to thank all the people that have been obviously contributing to our COVID-19 working group. this is just a slide to remind you of our annual conference, which will take place in a few weeks' time, 4th or 5th of November. This is going to be online, which hopefully will make easier for people to attend rather than in attendance. And yeah, thank you very much for your attention. I'm very happy to take your questions now. Thank you.
Thank you. Excellent and comprehensive presentation, Dr. Battisti.
Thank you very much, Nicolo. It was very comprehensive. There is some different topics in Turkey. We started a little late in terms of vaccination in Turkey, and we start with the Chinese vaccine with CoronaVac, and our older people all vaccinated with this type of vaccination, and then we can reach the mRNA vaccine, BioNTech vaccine, in about 3 or 4 months after the first vaccination. And we started to vaccination with BioNTech after 2 CoronaVac, and we have now our results. It's working after 2 Corona and 1 BioNTech is working as a serological antibody response assessment. And also we have our epidemiological data, vaccinated people protected from hospitalization and also from the death. In terms of anti-vaccine activities, in now very rapidly spreading all over the world, in terms of the understanding of the new vaccination activity in longer term results. What's your recommendation for SIOC in terms of older cancer people? What we can do in Turkey in collaboration with you?
Yeah, I guess that's a very good question, and it's a question with an incredibly vast scope, I would say, but that's very much outside my area of remit. That we should advocate for, obviously, more collaboration between different countries to really, support the vaccination programs also in countries where the rollout has started later compared with many European countries or in North America. We've seen very recently some positive signals from recent meetings at the UN, but I think as a healthcare professional, we have the responsibility of advocating for these approaches. Personally, in the clinic, I always cross this bridge with my patients. I always ask them whether they have been getting the jab, and I always make sure that I reassure them about their safety and their efficacy. Obviously, there are some initial signals suggesting that, again, in the older patient population, the efficacy may be lower compared to younger individuals, but I don't think that's enough ground to obviously decline this patient the benefit, the protection from the vaccines, precisely because they may well have much more to lose in terms of, again, higher rates of adverse outcomes with COVID-19. I've been seeing over the last 18 months an awful lot of isolation that might lead to functional, impairment, and several other problems in my older patient with breast cancer. And I guess, an additional benefit of vaccine rollout may actually be allowing our older patients to be able to, benefit as much as possible from the social support. I remember during the first months, we were recommending here in the UK all patients on myelosuppressive treatment to isolate. And I've seen patients really desperate to come and see us in the hospital because that was the only time they could actually get out of their home and see people. And I think in the older cancer patient population, this is a very concerning scenario. So I guess, yeah, I'm obviously very pro vaccines. First, because obviously there is evidence that these vaccines can protect our patients, but I think in the older age group there are additional benefits that actually make this even more attractive, again, in terms of especially limiting the risk of social isolation, functional impairments, and so on. Yeah.
Also conflicted about the social isolation is recommendation, but also in older cancer patients need caregivers, and some issue that is conflict about the recommendation, but we have to continue to protect them as possible as, and to treat them as possible as. And also, do you believe, I think the last period of pandemics today, some health providers also underestimate the issue of COVID-19 in terms of vaccination is protecting everybody, but in terms of cancer patients, especially older cancer patients, still in the risk of COVID-19 infection and also vaccinated. Do you think we have to underlie the issue of health workers to deal with cancer, especially older cancer patients? Also keep in mind still a pandemic is continuing.
Yeah, I absolutely agree. I think for the first point that you mentioned, that's a key concern. Initially, here in the UK, I've seen hospitals applying a very blanket policy for everybody, for every patient, limiting access of caregivers, for example, to our clinics and so on. I don't think that's necessarily the right way to go for the older cancer patient population. I think similarly to what we do in terms of cancer decision making, you should really adopt a personalized approach, and it should be up to us clinicians, obviously oncologists, hematologists, nurses, AHPs, to understand whether that person needs the support of a caregiver when he or she comes and sees us in the clinic or not. And we should actually be the ones deciding who is allowed to bring that patient, and whether anybody is allowed or not. So I think you really have to individualize that sort of decisions also, especially in the older patient population. The second aspect, I absolutely with you. I am very much radical here. I think all healthcare professionals should have really the ethical responsibility to be vaccinated and obviously to take their jabs as soon as possible, because you really don't want to cause any harm to your patients. And again, in the older cancer patient population, this harm can be quite significant. So again, here in the UK, we've been, I suppose, pretty good. It's not a particularly diffuse problem that I'm aware of. We just started yesterday with the third dose. I got mine yesterday, and everybody has started really, showing up in the vaccination clinics straight away as soon as we got the various emails. But I think we should, I suppose, as healthcare professionals, discuss this also with our colleagues, and wherever there is, I suppose, an issue of people that are not that willing to take their jabs, really, have frank discussions with them and say, are you really sure that you want to, expose your patients to these risks? And again, I'm just a doctor, but I suppose this should also be the responsibility of hospital management, and make sure that actually whoever you are employing is actually able and willing to protect, our patients.
A burning question for Turkish people. What about the cardiovascular complication after mRNA vaccination for elderly cancer patient? Also, you recommend the low dose aspirin after vaccination?
Thank you. To be honest, I'm no expert in terms of cardiovascular disease. I'm aware that there have been reports of pericarditis or various other complications on the vaccines. But my personal opinion is that these are absolutely negligible compared with the benefits that vaccination programs have been, giving to our older patients with cancer. We really don't want to deny this very vulnerable patient population for such an important layer of protection. In terms of aspirin, I'm not sure, to be honest. I wouldn't necessarily do that. I'm worried that aspirin does many very good things. Some people even give it for cancer prevention in some countries, but I wouldn't necessarily consider that for older patients receiving a vaccine. These patients, if they have active cancer, obviously they would have already a high risk of venous thrombosis. They may have cardiovascular disease because they have comorbidities. Some may already be on aspirin because of other problems. Some may already be on other blood thinner, low molecular weight heparin, whatever. But I wouldn't necessarily, support the use of aspirin simply to minimize the risk of these events in older patients with cancer receiving a vaccine.
In terms of hematology field, we are also responsible for the treatment of the COVID-19 patients as well, beyond hematological malignancies, because of the clinical picture is also inflammatory response syndrome, and also the treatment option could be managed by the hematologist as well. And we all experience with some kind of treatment option, anti-inflammatory, and also the immune plasma treatment option in COVID-19. And we learned a lot from these issues. We have to protect all cancer patients, especially in hematological cancer patients, because they are already immune paralyzed and already immune system is different activities as well. After COVID-19 is also changing dramatically, and also our treatment options, especially for our chronic lymphoproliferative disorders such as CLL, lymphoma, indolent lymphomas, and myeloma, they are all immune compromised. That's why we have to keep in mind the protection is important than the treatment of COVID-19.
Nicola, practical questions. If a patient has cancer, do you think COVID infection or COVID vaccine predispose to disease progression?
That's a very good point, but I'm not aware of any evidence suggesting that. Again, I work in the solid tumor field, but that wouldn't necessarily be my concern. I guess we will understand an awful lot of things from real-world series, real-world data when it comes to long-term safety of these vaccines, but that's nothing that would definitely sounds like a red flag to me. Obviously these vaccines are include different some are mRNA, some are adenoviruses, whatever, but I wouldn't necessarily expect that from happening. And again, what I am very worried about short-term adverse outcomes in this patient population. What I always say to my patients in the clinic when they have some, concerns about potential risks of receiving a vaccine, I always say, listen, we don't really want your, apart from, you're protecting you against COVID-19 and, ending up in a hospital, maybe in ITU, intubated and so on. A key aspect, we don't want your treatment, your anti-cancer treatment, which is now, working, maybe your disease is very well controlled on it. We don't want it to stop. And if you catch COVID-19, given that that's an immunosuppressive treatment, we might need to hold it for a while, and then your cancer may be free to progress and cause you symptoms and impacts on the quality of life. Stopping an effective treatment, that is what can cause disease progression. Personally, I had a few patients having a very effective treatment with a very good ongoing disease control, that in the very early days of the pandemic last year, they had to stop the treatment. Somebody has gone to ITU, or somebody just admitted as an inpatient, and then after they had to stay off the treatment for 3 or more months, and obviously the cancer has progressed. So I would be very, very wary of these sort of messages, and we really need to base our recommendations, our discussion with patients, what is the evidence available. And but I wouldn't necessarily, based on how this vaccine work, I wouldn't necessarily think that that's a concern.
Dr. Cordoba?
Nicolo, thank you very much for joining us. It's been a pleasure and an honor to have SIOC President-elect in this joint workshop between SIOC and the Turkish Geriatric Hematology Association. So thank you very much for joining us. I have 2 very short questions for you. The first one is regarding the electronic geriatric assessment. I don't know if you have experience or if you are aware of any initiative that has been implemented in the COVID-19 pandemic, because I am aware of some initiatives in the United States, but not something that has been implemented in this pandemic. Do you have any experience using that?
Yeah, thank you, Raul. I would say mostly from North America, and as I mentioned, the University of Rochester team have been using a remote approach within the pandemic. They published also their experience on Journal of Geriatric Oncology, and I guess that was a very nice example of how we can practically still use geriatric assessment to inform personalized treatment decisions, even in the context of the pandemic. I am not aware of any, to be honest, anybody in my country here in the UK. But as I said, I would really encourage everybody, all our attendees today, to consider still using this assessment. Again, maybe some simple geriatric screening tools to better inform your decision. And these screening tools can be delivered remotely. Again, G8, VES13, they're very, very, very extensively validated in the older cancer patient population, and you can deliver them over the phone or in video consultations, and again use that additional information to again inform your discussion with patients. Pragmatically, I think you also need to understand what is available in our own institution, whether you have, for example, access to a multidisciplinary team that can comprehensively look after all the patients with cancer, whether you have access to geriatricians, whether you have access to dedicated nurses or allied professionals, and then based on that, choose the tool that is most likely to be feasible in your own institution. As you know, Raul, there are an awful lot of tools that have been validated in the older cancer patient population, and you know, when we speak to geriatricians, the general feeling is that it doesn't perhaps matter which one you use, as long as you use one to actually screen these patients for frailty and vulnerability, which is so important, especially in the context of COVID-19, which is really, I suppose, raised the bar for these patients and made things incredibly more complicated in terms of cancer management.
My final question is related to something that you have mentioned in your talk, that is about social isolation. All the patients can suffer from this isolation, and can you give us any tips if we have to face again a lockdown in order to not to worsen the functionality of our older patients with cancer?
Yeah. I would say the key aspect is really to keep, especially if you still have high rates of transmission in your own in your area, in your geographical area, in your country. Make sure that you still counsel patients about the importance of not mixing up with too many people, and obviously also the importance of counseling them about getting vaccinated. And to be honest, I've been using that argument a lot to, I wouldn't say convince, because most patients that I've seen actually been very happy to be vaccinated, but it's an argument to, favor the uptake of the vaccine in our patient population. If you get vaccinated, you may be, more easily able to get, the support that you need from your family, from your friends, from your neighbors, and so on. And to be honest, I think at the very beginning of the pandemic last year, again, especially in this country, we were advising everybody to self-isolate if people were on myelosuppressive treatment. Now we are far more relaxed now. And I think, you do not necessarily need to advise patients to self-isolate even if they are on myelosuppressive treatment, but you can still, they can still practice, social distancing and be cautious even, when going to, to have a nice walk in the park or in gardens, or do grocery shopping and so on. Use the masks. Keep complying with the number of interventions that now we really got used to over the last 18 months. So I think I see all these approaches, obviously the vaccination program and the community-based interventions in terms of, social distancing, mask use and so on, as resources that actually you can keep using to make sure that your patients experience the best outcomes from the treatment. And when it comes to, again, specifically the older patient population, again, this doesn't necessarily does no longer involve restricting access to the social bubble and so on, because as you say, Raul, this has been a big source of concern for these patients. Our patients require additional support at home and in the community, and we should make sure that they have this opportunity again, while getting to know what's going on in our area, and with the help of the vaccination program. What I am personally worry about is obviously all the new variants that may be popping up in the next months, years. And again, I guess that's an additional argument to make sure that we reach adequate uptake of various vaccination programs in all countries, to be honest. But yeah, as I say, that's a much more complex topic and matter that perhaps should involve governments rather than clinicians.
Thank you.
Thank you.
Thank you.
I'd like to thank all speakers for excellent presentation. The workshop, first joint workshop with SIOC. I think that the workshop is useful for participation. If you any question, the session is closed. I hope so. See you next joint workshop with SIOC.
Thank you very much for having me.
We will meet in SIOC meeting virtually, and then we can meet together as well as possible, as soon as possible in terms of in Turkey. Next year we will be together in Turkey, we hope. We are very grateful to make a opportunity to join workshop with SIOC. We would like to thank President-elect Nicolo and Professor Cordoba for their support and their presence in here. We are very thankful for you.
Thank you very much for having us. It's been our pleasure.
Nicolo, thank
you.
you.
Look forward to more collaboration.
See you soon, face to face.
Thank you.
Bye.
Bye-bye.
Değerli katılımcılar, bugün SİOK'la yapmış olduğumuz toplantıyı burada bitirdik. Ama yarın sabah saat 9'da Türkiye'mizin çok değerli uzman tartışmacılarla beraber orijinal konuları beraber değerlendireceğiz. İnteraktif bir toplantı düşünüyoruz. Hepinizi yarın sabahki Geriatrik Hematoloji Derneği düzeninde 10. Geriatrik Hematoloji Kongresi'ne bekliyoruz. Hepinize iyi akşamlar. Sevgiyle kalın. İyi ki varsın.